while all the other chairmen and panelists are coming, I would like just to thank obviously Fernando Alfonso for his kind invitation. Oh, okay, we will start with the questions. That's right. So we start with the questions and then we go ahead. So first question, it's in what type of de novo lesion do you use DCB more frequently? Small vessel, diffuse disease, bifurcation, and CTOs. Let's vote all. Up to now it's quite, I will put my vote so that, okay, it seems that small vessel is winning. Do we have the panelists so that we can ask the panelists, no? Nacho Amat and José Ramón López Mínguez. Go ahead with the first question.
I think yes, I agree totally with the results. Small vessel probably is the niche in which there is more evidence. And bifurcation, from my point of view, is an option, but there are not enough studies just to decide if it's better or not. Diffuse disease is another good option, of course, and CTOs, I have no idea.
Okay, Nacho, what's your opinion?
For me, diffuse disease is like the rule, where I use DCBs, especially distally to CTOs afterwards. But the quickest growing indication is small vessel. So.
Okay. Do we go ahead with the second question? Okay. In true coronary bifurcations, first, I try to treat both branches using DCB alone without drug-eluting stent. Second, I use provisional stenting with DCB in the side branch. And third, I never use DCBs in bifurcations. Let's vote. Okay, it seems that the first option is the one that wins. I think that José Ramón López Mínguez has some, no? He's an expert. He published already a study. So go ahead, panelists, please.
Yes, I think the first option is probably the most used in our labs. At least you don't know if you are going to get enough benefit, but at least you are not going to have any damage. So probably you can get some benefit. We don't know how much. That's the point. The second options, I think that as the proximal bifurcation is free of lesion, it could be a very good option. But always if it's a 0-1-1 lesion. Yeah.
Okay, Ignacio?
Very often we use it in the first option. I would say we have never used it in the second option, in the second indication, because the carina is a concern, and I mean, if it's so small to consider this alternative, we would go with provisional stenting probably.
Okay, let's move to the third question. Do you have more questions, Fernando? Yeah. Okay, in what clinical scenario do you believe DCBs are more useful? First is high bleeding risk, second, acute myocardial infarction, and third, diabetes. Okay. So I think high bleeding risk is the winner. Do you want chairmen or panelists? Do you want to make any comment about?
Yeah, I agree totally. High bleeding risk is a clinical scenario that every one of us would like to have options. So it's a very good. In diabetes, I think it's not a good option because diabetes, we have seen some follow-ups, and these kind of patients always need, from my point of view, diluting stent. And in acute myocardial infarction could be a good option in some kind of lesions. For example, in bifurcations with thrombus. And it's a scenario in which sometimes you don't know exactly what is the real diameter of the vessel due to the vasoconstriction. And I think when you don't want to be very aggressive, this is a very good option in some.
Very good. Nacho, do you have any?
I think we need more data in high bleeding risk, because it's true that you can shorten the length stented, but at the same time, when you just use DCB, you are going to leave some dissections behind. So how short can you do the APT, especially in acute settings?
Okay, let's move. Let's see if there is any other question. No, there's no more questions. So first, let me present the chairmans, Dr. Simon Ecclesall and Raul Moreno, that are with me. And I think that we have done these questions because the niche of in-stent restenosis is probably the most accepted for DCBs, but other niche, other clinical scenarios are to be inspected and to know more about that. And for that, I want to present the first speaker, who's going to be Robin Jaeger, and who's going to explain us about DCB in small vessels and clinical outcomes.
Thank you very much. As you heard, small vessels are today the most frequent indication for DCB use. It all started with this trial. PEPCAT-1 was published in 2010, and this was a single-arm study where the sequent please generation 1 was used in small vessels between 2.25 and 2.75 millimeters, and they looked at MACE at 12 months. And you see here that in this data, the TLR rate in a drug-coated balloon only was very low at about 5%, whereas in a group where DCBs were used in combination with bare metal stents, there was an incredibly high TLR rate of 28%, and with this trial we learned that geographical mismatch is an issue, so if you don't use the DCB in the right position, you have a problem. The other results, including stent thrombosis or lesion thrombosis more, it's not a stent in a DCB-only approach, were really low. We probably come back to the long-term results afterwards, but you can see here that the long-term rates of events are really low when a DCB-only approach was used. Then there was a randomized trial, the Piccoletto-1 trial. Bernardo, you probably remember that. You were young and active and full of motivation. Yes, and this was a randomized non-inferiority study. The DOR1 DCB was used. This is a DCB that is not existing anymore, was used against the Taxus Liberté. It's gone also. And in these small vessels, you saw really not a good result for both groups, but the paclitaxel-coated balloon, the DOR1, was really performing in a horrible way, with a MACE rate of 1/3 of patients, whereas the Taxus stents was at 15 or 14%, and this was almost killing the whole topic. And therefore, Antonio Colombo and his group, they started with the Bello trial about the same time, 2012, this was published. And in this trial, the IMPACT DCB, I think that time was a peripheral balloon, was used against the Taxus Liberté and had a good performance. You see here that the primary endpoint was late lumen loss at 6 months, and the drug-coated balloon was performing well. The clinical data was acceptable as well, and so this was the first randomized trial in the field with small vessels that was successful for the DCB. We will probably hear about late-term data afterwards, but it's about the same picture. DCBs, when they have the rough time after them, they perform really well. And now I show you the data for basket small 2. At that time, when we started the trial, I was not a believer in this, but we did a series of basket trials. This was a series of trials, BMS versus DS, DS first generation against DS second generation. And in the subgroup analysis, we saw that in small vessels, the DS were performing not in a good way. And therefore, we looked for other possibilities to have better results. The basket small 1 was a comparison between two different DES, included the co-star, which was horrible performing. And then we switched to a DCB, and this trial was quite successful because with this trial of about 750 patients, we could show non-inferiority between DCB and second generation DS. Having said that, I have to admit that 1/4 of the DES patients were Taxus patients, second generation Taxus stents that were not performing well, but the science stent as a comparator against the DCB was performing in a similar way. I don't show the data here, but there was no difference between the two comparisons. What could be of interest is there a difference between smaller and bigger vessels in this field? We did a subgroup analysis here from basket small 2, and there's no sign that size matters. And if you extrapolate this could be that I think in larger vessels, larger than 3 millimeters, there will be the same situation like here. This slide was shown before. This was the angiographic analysis, and I show you because there has lots of discussions about thrombosis or acute vessel closures. This is it's a box plots for late lumen loss, for diameter stenosis and minimal lumen diameter, and you see here in DES in blue and DCB in red, there's no difference except these little guys here. And these little guys, there were 8 acute thrombotic vessel occlusions with drug-eluting stents, but there was no vessel occlusions with drug-coated balloons. And the clinical presentation of those events was quite harsh, STEMIs, non-STEMIs, and heart failure. And all these patients, except one, were on dual antiplatelet therapy. And based on this data, you can say, if you have a problem in small vessels, it's an acute stent thrombosis and not an acute recoil of the DCB-treated lesion. There is now some other data, not only those data I showed you, more modern data. This is the Restore SVD China trial. There's a paclitaxel-coated balloon called Restore. They did a trial in China, and you see here that the angiographic analysis is really good here, and also the long-term data is about 230 patients enrolled. The clinical data is after 5 years is quite good, and there's no sign that this DCB is not working, seems to work well. And again, Bernardo has done the Picoletos 2 trial with the more modern version of the Aachen Resonance DCB. It's the Elutax SV, and here you see a comparison between the DCB and the science stent. Excellent result. after 6 months angiographically and also clinically, and you probably will see this data afterwards. This is the 3-year outcome of this trial. So my take-home messages here is that we don't have the official ESC guideline support for small vessels and DCB, but this small de novo coronary artery disease has really become the classical indication for DCB use. The first trials were done either with DCBs that were not working or with comparisons with Taxus stents that were not working as well, and so we have to rely on the more modern data between effective DCB and modern stents. The paclitaxel-coated DCB, they show short-term non-inferiority, but also a long-term clinical result that is sustained and good. And we still wait for the data from sirolimus-coated balloons, but we probably will hear more and more during the day. So I thank you for the attention and give back to the chairs.
Fernando, we were planning about doing the discussion after all the presentations, no? Okay. So the next presentation is also related with small vessels. It's Bernardo Cortese is a very well-known expert in this field. He's going also to speak about small vessels, focused on mechanisms and late angiographic results.
Yeah, thank you, Raul. Actually, yeah, I couldn't find so many data regarding late angiographic outcome of DCB, but yeah, they're not immediate. For sure, we know that the performance, the angiographic performance of currently available drug-eluting stents is not perfect in the small vessel disease setting due to the encumbrance and to the amount of neointima hyperplasia and later neoatherosclerosis that is occluding a vessel which is already small. And the clinical outcome as well with drug-eluting stents is, you know, it's not very performing in the small or very small vessel disease setting with these events that are going to accumulate within the years after the implantation. So we already discussed about Piccoletto 2. Also Fernando was an important center for enrolling patients in this study. It's an independent study sponsorized also by GISE. The study enrolled patients before lesion preparation to Elutax SV and Xience everolimus eluting stent. So this was the first comparison with a currently available and used drug eluting stent, and the primary endpoint was late lumen loss assessed by a core lab, and then we have the clinical follow-up which now arrives at 3 years. We have just seen this slide. Drug-eluting stent did perform as we expected also from the SPIRIT trial, so late loss in this setting was between 115 and 120, and then 015 and 020, 017 overall, but we did not expect such a good outcome in the paclitaxel-coated balloon group with performance in late loss of 0.04 with a good lumen enlargement in about 2/3 of the patients. As expected and as we have seen from other trials, the other angiographic parameters were quite normal in terms of person diameter stenosis, no differences between drug-eluting stent and drug-coated balloons. This is something that we already know. Binary stenosis, quite the same. This is true for the in-lesion analysis and also for the in-segment analysis. Then we have Restore SVD, another paclitaxel-coated balloon. This trial was powered with a different primary endpoint, but still a mechanistic trial. Person diameter stenosis was the primary endpoint at 9 months angiographic follow-up, and here the comparator was not Xience, but Resolute drug-eluting stent. We have seen the data here. There is no differences in terms of primary endpoint or person diameter stenosis, so the non-inferiority which was expected was encountered. What is different from the other study that I have just presented is the late loss. Here is a little bit higher. With the restore is 0.26 in device and in segment 0.25. So it's more than expected, and from what we have seen with other balloons also in Piccoletto 2. And also the late loss in the restore DES is a little bit higher than the one that he has seen with the Zion stent. But it's difficult to compare different studies, different mechanistic study. This is another study that I recently found with a balloon that I was not aware of. It's a bingo balloon. Do you know about bingo balloon? No. It's a Chinese balloon eluting paclitaxel. It seems a good, well-working balloon. Here the small vessel is the side branch. They compare the left main, two-stent group versus DCB in the side branch, usually the circ, and the drug-eluting stent in the main vessel. This is the outcome in the main vessel and in the LAD, so stent is working like this in this vessel, so not a specific issue. But if we compare the second stent in the side branch, which is a small vessel, because MLD is 2.4, it's 0.43, the late loss with the stent, and it's a negative 0.17 with a drug-coated balloon. This data is already known in other small series of studies done with a bifurcation where there is often a negative late lumen loss when you use paclitaxel in the side branch. Another important information that we can have with this is something that we expected from the BRS, but actually we didn't have, is the vasoreactivity that we encounter after the implantation of a drug-coated balloon, the use of a drug-coated balloon as compared to the implantation of drug-eluting stent. This is a mechanistic but very well done study. It's a randomized study between drug-coated balloon and drug-eluting stent. This is the angiographic parameters that we are not going to go deep into them, but what is interesting is that the reactivity of the vessel in the segment and also distally was much higher in the DCB arm, either with small dosage or with high dosages of acetylcholine and also after nitrates put into the segment, with a significant difference in the distal segment with acetylcholine and a significant difference in the treated segment with the nitrates. So something that I would say more respectful for the vessels of our patients. Then we have sirolimus. We have limited data. As Raban was saying before, we have this data. Just take the below part with the de novo. This is a comparison versus paclitaxel. What the information that we have is that we don't have such a pronounced late lumen enlargement with sirolimus. We have it more than with POBA, but in around 25–30% of the patients. In this study, this is the B Brown balloon with a good late lumen loss. Then we have the data, the only available with a solution. I'm not aware of publication of this study. I was there with Stefan when he presented it. This is a blended study with ISR. There are few ISR, and mostly are de novo lesions, and here the late lumen loss is 0.26, but probably is a little bit higher because there are also some ISR patients. And then we have the Magic Touch data. We have published these studies, natives, it's prospective registries of consecutive patients, 25, 26 that we enrolled, 27 that we enrolled a few years ago, and all of them underwent angiographic follow-up. After 6 months, we had a core lab which nicely analyzed the performance of this device. Acute performance was good, and we observed a late lumen loss of 0.09 in this true small vessel disease study with a minimal lumen diameter of 2.14 after 6 months from the enrollment of the patients. And then we have the ongoing Transform 1 study. This is a sponsored study by the company. It's a direct comparison and randomization between Sequent Please and Magic Touch after successful lesion preparation and after that all of the patients have undergone an OCT analysis, a deep OCT analysis. We are investigating into the outcome of this study, and I believe that the results will come out soon. So we have several studies, several devices having addressed the angiographic performance of several drug-coated balloons in the small vessel disease setting. You can see that there is not a class effect. Some of them are working better, some of them are working less in a, I would say, less good way. So my conclusion, midterm angiographic performance of drug-coated balloons is higher in terms of late lumen loss and similar in terms of percent diameter stenosis as compared to current generation drug-eluting stents. We have data from now from different devices. Obviously, late lumen loss, I don't want to come into the same polemics that is favoring drug-coated balloons. At least it's favoring paclitaxel-coated balloons, but the lumen enlargement is there, and it's a good news. Some paclitaxel-coated balloons, as I said, after, this is an important point, adequate lesion preparation are showing a clear lumen enlargement. Some of them, not all of them. There is not also class effect in the paclitaxel subgroup of DCB. Some sirolimus preliminary data shows some promising performance, but with lower or not there lumen enlargement with this type of device. We don't know if lumen enlargement will convey into a better clinical performance on the long term. Thank you for your attention.
Fantastic, thank you, Bernardo. It's Bruno up next telling us how he likes to do bifurcations, which is probably one of my most favourite topics. And if there's a company out there that wants to do a bifurcation study in DCB, now's the time to do it. Bruno.
Yeah. Unfortunately, we have not that much evidence so far. That's our limitation for the bifurcation. So we have different scenarios for the use of DCB in bifurcation. The first that was in the beginning investigated was the idea to implant a bare metal stent in the main branch and use the DCB in the main and in the side branch. For this we have, for example, the publication of the Babylon trial. The restenosis rates are in the main branch 14%, which I think is relatively high versus 2% in the ES group, and also in the side branch the ES group performed better than this combined approach. And meanwhile, we have clearly left the concept of combining a DCB with a metal stent because this does not really work. The most popular approach is implanting a drug-eluting stent in the main branch and then deciding if you can use the DCB for the side branch. This is the most accepted indication, I would say, and we have some data. There is data from the Biolox 1 study showing late lumen loss in the side branch of 0.1 and in the main branch of 0.28 millimeter on average. I think this is acceptable and shows the feasibility. The next comparison between using a conventional balloon angioplasty in the side branch and a DCB in the side branch when stenting the main branch has been published by the Spanish group. And here again we see the feasibility of this approach, implanting a stent in the main branch and using a balloon-based approach in the side branch. And here we see an angiographic benefit when using DCB in the side branch with a significant reduction of late lumen loss compared to conventional angioplasty. Similar outcomes from the PEPGAD BIF trial, which was a randomized trial we conducted in Germany, and we focused only on the treatment of the side branch, and the operator was free to treat the main branch also with DCB only, or to use a drug-eluting stent. So this was due to the operator, and here we could show, which was not that big surprise, that DCB in the side branch improves the angiographic outcomes with a reduction of late lumen loss in segment here from 0.47 with POBA to 0.08 millimeter. So I think angiographically, with the angiographic data, it makes sense to treat the side branch with DCB. However, the question is, does this improve patient's outcome? I think this is questionable. Now to the two more puristic approaches, which I'm in favor. The idea is, as suggested also in the consensus paper, first to predilate the main branch, then to predilate the side branch. If the side branch is okay after lesion preparation, use the DCB in the side branch. And then if the main branch still looks acceptable, use also a DCB in the main branch. If not, implant the drug-eluting stent in the main branch. So that's this relatively simple approach we recommend. There is some data. We have here this series from Franz Kleber published in 30 patients with a MACE rate of 7.7%. Then we have the registry, which has been published for bifurcation treatment. In total, 127 patients with 130 lesions, and 70 patients underwent treatment with DCB only in both branches, and 57 patients, 60 lesions, this hybrid or blended approach with stent in the main branch and DCB in the side branch. The clinical outcome was fine with relatively low event rate, but this is only registry and not randomized data. Here again, this concept. This is a patient from the PEPCAD-BIF trial with this lesion in the circumflex. Lesion preparation, predilatation. Then here you see a carina shift from the main circ to the posterolateral branch. Nevertheless, we used two DCB, paclitaxel-coated sequin Bliss balloons, first to the posterolateral branch, then to the main circ, and this was the initial result. There is haziness. I think if you do QCA, you would not reach the 30% goal we have in our consensus recommendation. And this was 6 months later with field dissection and some kind of lumen enlargement in this situation. This is another example, a trifurcation in the right coronary artery, sequential predilatation of all three branches, and then three sequin Bliss in a row. This was the primary result. The quality is not that good, but here we had a dissection in this mid part, relatively long but not flow limiting. And this is angiographic outcomes 13 months later. Again, you can see that the dissection has healed and the lumen has improved. So I think this is a very simple approach to treat bifurcation without the need of a very complex stent procedure compared to the multiple stent strategy. And this is another concept. If you have, let's say, a 3.0 or 3.5 vessel, and you have a side branch which you can treat, but you are sure it makes not really sense to treat the side branch. This could be the option only to use the DCB in the main branch, DCB only, and forget the side branch. And after 9 months, here, as you can see in this very nice data again from Dr. Shin from Korea, the ostium of the side branch improves. And this is the simplest way to treat bifurcation that we can imagine. So these are the 4 scenarios. DCB plus bare metal is outdated. This is not recommended for sure. The most accepted approach, this was my feeling from the European Bifurcation Club too, is to use a stent in the main branch and use the DCB for the side branch. My concern is that this looks nice for the side branch, but in clinical event rate, it will not benefit the patient, in my opinion. And then we have this concept of a totally new approach, which for me it's much more simple than a two-stent approach. Applying the rules of DCB only, pre-dilatation, if acceptable, use DCB, and the same applies for both branches. And you can do it sequentially, you don't have to do kissing, you can do kissing at the end of the procedure, but it's not necessary. And then the special case with a small side branch, where you may be in a position only to treat the main branch and forget the side branch. So that's what I think about bifurcations. And we have now science, as Simon already mentioned, that EBC is now willing to conduct such a trial.
So thank you very much, Dr. Scherer. Let's move to the next talk, which is DCB for acute myocardial infarction. It will be Arturo García Tuchard, who also has published studies around this clinical scenario.
Good afternoon to everyone, and thank you, Fernando, for inviting me again to this meeting, this interesting meeting. I'm going to talk about the drug-coated balloon in an acute myocardial infarction. So, primary PCI with drug-eluting stent is the guideline recommended treatment strategy for patients with ST elevation myocardial infarction, but still have a negative aspect, such the presence of late malapposition due to the thrombus dissolution, or the presence of uncovered stent. These both will lead to late negative events. And these negative late events has been shown in the two main clinical trials with drug-eluting stent in acute myocardial infarction, where you can see here that it is an increased rate over the time of target lesion vessel acute myocardial infarction, an increased rate of stent thrombosis, and an increased rate of target lesion revascularization. So that means that drug-eluting stent is not the perfect strategy for treatment acute myocardial infarction. So we have to try to find this a better strategy. So in this setting, maybe drug-eluting balloon are the ideal treatment for STEMI, as we show in talks before, that it apply a more homogeneous drug impregnation. They do not carry polymer, and it give to the artery a high and brief drug tissue concentration, which may lead to better outcomes in acute myocardial infarction. So the drug-coated balloon has been studied in many scenarios, which I resume over here. There are three possible scenarios. The first one, letter A, is after lesion preparation, just apply a drug-coating balloon, leave nothing behind strategy. The second strategy is after lesion preparation, apply a paclitaxel balloon and then use a bare metal stent. And the third strategy is after lesion preparation, we implant a stent and then apply, once the stent is implanted, the paclitaxel eluting balloon. And all these strategies has been tested in both in STEMI clinical trials that I show here and in non-clinical trials. But since this talk is very short, I only will focus on the result of the in the clinical trials. So the first one, clinical trial, is the Revelation trial. It's a number A strategy. After lesion preparation, they apply a Pantera Lux balloon, 60 patients, and compare them with a drug-eluting stent or zero or a science stent. The primary endpoint was 9 months FFR. And the result of this study is shown here, that there is a positive study. There is no difference between the two strategies in the acute myocardial infarction. This study is a good study, but it has some negative aspect, like they only recruit for FFR nearly half of the patients for both arms, so maybe it has a low power. The second clinical trial is the DEP-AMI trial. They compare the second strategy, number B, so after lesion preparation, they apply paclitaxel over the thrombus and then implanted the stent. And they compare this strategy against a bare metal stent or a drug-eluting stent. The primary endpoint of this study was 6 months in stent late lumen loss. And these are the results of this study, very well known for everyone. And this study was negative. The drug-eluting stent beat the drug-coating balloon strategy, and the drug-coating balloon strategy had a similar result in late lumen loss as the bare metal stent. The third strategy, number C, is after lesion preparation, implant a stent and then apply the paclitaxel balloon. This was our study. We use Pantera Lux, and we compare this strategy with a bare metal stent, which was the recommended strategy in the former guidelines when we developed this study. The primary endpoint was the 9-month in segment late lumen loss, and these are the result of the study. It was a positive study. We show that the paclitaxel balloon group shows much better outcomes regarding late lumen loss compared with bare metal stents. And also, the result of our trial show at 1 month a very good 1 year clinical events with just one definite stent thrombosis in the paclitaxel arm and less than 2% of ischemia-driven target-less revascularization. These are some picture from our trial. On the left, the index procedure and 9 months procedure on the right. And the other strategy was our PEPC2 trial. We wanted to compare our strategy, first stent, bare metal stent, after then use a Pantera Lux, and we wanted to compare with a drug-eluting stent. But our study was prematurely halted after the recruitment of 206 patients due to the slow recruitment and due to the COVID pandemic. But we have this data, hopefully we will publish it. There are some data regarding drug-coating balloon and OCT studies in the acute myocardial infarction. We only have data on the studies with use stent. These results are really good. Okay, so in both trials, the DEP-AMI trial, it shows that the drug-coating balloon strategy achieved almost 100% of complete strat per lesion, and just 1% of the strat malapause per lesion. The same result we obtained in our PEPC trial. Nearly at 9 months, nearly 100% of the strat were coverage, and just 1% of strat per lesion were found malapause. This is a for me, a very important slide. This is our study in the sub-study of the OCT PEPC2 study. In this study, we show by OCT that the paclitaxel balloon have a different healing compared with the drug-eluting stent. This is very important because if we have a different healing, maybe we can get different outcome at the follow-up. And we find in this study that the drug-coating balloon strategy had and homogeneous neointimal layer, compare 70% of homogeneous neointimal layer compared with just 20% of the homogeneous neointimal layer in the DES group. This neointimal layer homogeneous, it's a very stable neointimal tissue. And we also find a lower major coronary evagination, 30% at 3 months in the paclitaxel group against versus 68% in the drug-eluting stent group. The major coronary evagination has shown to be a marker of late stent thrombosis over the time. And what about the drug-coating balloon follow-up study in the STEMI? We have almost no data. We have only one trial published. The Revelation trial, a 2-year follow-up, is the letter A strategy. Just use a Pantera Lux balloon as leave nothing behind. And at 2 years, the results are similar between drug-coating balloon and drug-eluting stent. But you have to think about that there is a very low patients. We have the data of our Pepsi-1 trial, 8-year follow-up. I hope can publish it very soon. We are at the 3rd round of review in one journal, so maybe the next year I will tell you the result. But these are really encouraging results. So, in conclusions, paclitaxel balloons in STEMI about healing induce a distinct and superior healing compared with drug-eluting stent. It shows an homogeneous neointimal and much less major coronary evagination. Regarding effectiveness, they are really effective, but just using soft endpoints as FFR or late lumen loss. Regarding safety, they are very safe. If you see by OCT, with nearly 100% of stent cover and just 1% of malapause stent per lesion, and the very long-term result, they are needed to definitely define the safety and efficacy of this device. We have the 2-year Revelation data that I show you, and we will very soon publish the 8-year follow-up of our study. And the last, that a drug-coating balloon clinical trial with a clinical endpoint is really needed in order to definitely demonstrate that the drug-coating balloon strategy is a better strategy than the current use of drug-eluting stent in STEMI. Thank you very much.
Thank you, Arturo. Next speaker is Thomas Risanen, comes from Finland, and he's going to speak about the clinical context that was most frequently supported in the question we raised at the beginning. So I think it's a very interesting scenario.
Thank you, Mr. Chairman, and I would like to thank for the kind invitation to the beautiful city and meeting. So I come from the farmost eastern part of EU and also fortunately NATO since last month. These are my disclosures. I think the most important one is that we have used a lot of DCB in the past few years, already over a decade. So these issues are, I think, very important that are positive for DCB-only approach, and I will concentrate on the bleeding risk patients. So we know from the studies done on patients having NOACs and also stent trials on high bleeding risk patients that BARC 2 to 5 bleeding is very frequent after PCI, and half of the bleedings occur after the first month, which is the most critical timing. And 40% of all patients undergoing PCI are at bleeding risk. This has been shown in large registry studies in Japan and also in Europe. And if bleeding occurs, the mortality risk is very high. So a few years ago we published this landmark trial, debut trial, where we investigated drug-coated only PCI in HBR patients. We did predilation according to the guidelines, and patients were old, 77 years, and we had 200 patients, 100 per group. We used BMS as a comparator because at that time when we started this trial, it was recommended by the ESC guidelines. The vessels were large, about 3 millimeters in size, and as we randomized the patients after successful predilatation, only 2% required bale metal stenting after PCI. And obturations were similar between the groups. The primary endpoint was MACE at 9 months, and there was not only non-inferiority but also superiority of DCB-only approach against BMS, and this effect sustained until 3 years. There were no acute occlusions after DCB-only PCI. We also did a post hoc analysis on mortality. This was not pre-specified, but hypothesis generating, and we saw a difference between this group in terms of mortality. And this is also very, very interesting. And also within the basket 2 small trial, there was a significant proportion of patients at bleeding risk, about 20% of the whole population. And there was a pre-specified analysis of this population, and there was a difference between DAPT durations in stable CAD patients. It was 4 weeks after DCB and 6 months after DES groups. And because of this reason, I believe that there's a trend towards less bleeding severe ones after DCB versus DES. There was no difference in MACE between these 2 groups. But then we have done, during the last 10 years, quite a lot of extremely high-risk bleeding risk patients with a single antiplatelet therapy and DCB-only approach. And I think this could be a novel concept. This is a very extreme patient, young patient with hemophilia and type 1 diabetes, presented with unstable angina a few years ago, and there was a tight LAD stenosis, and there was a strong recommendation from the hematological side not to give P2Y12 inhibitors to this patient at any time. Of course, one vessel capitage maybe not the best option, so we were brave enough to try DCB-only approach. We gave only aspirin and a little bit low molecular weight heparin, no P2Y12 receptor blocker, did predilation with the cutting balloon, and then paclitaxel balloon. This is the initial result with some non-flow limiting dissection in the LAD. Surprisingly, also the diagonal dissected, even though we didn't do anything on that vessel. The patient was stable, no ECG changes, and no pain, and was discharged on aspirin only. 5 years later, unfortunately, the patient didn't take statins and came back of stable angina. You can see here that the DCB-treated segment of the LAD looks fine. There is positive remodeling, diagonal has healed, but there is a moderate stenosis in the proximal LAD, which was positive for ischemia. And we again did DCB only here. At this time we gave heparin, and aspirin was there, and as recently we have used in this kind of patients, we did perioperative gangrel infusion and 4-hour infusion after PCI. And this was treated with 1 drug-coated balloon, and this is the final result. And for 3 years the patient hasn't have angina, no bleeding complication, and this is the final result. This is another extreme patient, elderly patient with cancer, active bleeding as coming to the hospital, and also NSTEMI and ongoing chest pain. Angiogram presented 111 LAD stenosis, and surgeons and anesthesiologists said that this patient cannot be operated without revascularization. And again, because of the malignancy, CABG was not an option in our opinion. And we tried the DCB-only approach. Again, we didn't give any P2Y12 inhibitors, and did NC balloon predilatations as we quite often do. And you can see the initial result, and then another angle which is very, very important before you consider DCB-only approach. There's a little bit dissection, but flow is normal, no pain, no ECG changes. So I think this is suitable for DCB-only approach. We did a long application of DCB. Quite often in this kind of tight stenosis, there's good preconditioning, and you can keep the balloon open longer than 30 seconds. This is the initial final result showing good TIMI flow, and again only aspirin was continued. Well, the patient was not compliant to aspirin and stopped it, and we were very happy not to put a stent in this patient, and we had control angio 4 months later, and you can see some positive remodeling. A little bit dissection is still to be healed, but the patient hasn't have any cardiac symptoms 5 years from that PCI. So, as you all know, DAPT was initially developed for prevention of stent thrombosis. Of course, after ACS, it has shown effect in secondary prevention of ischemic events, but the hypothesis of this approach is that the lack of permanent metallic implant could allow single antiplatelet therapy and maybe lead to fewer bleeding complications. And we studied this approach in our single center population. This was published early this year in CCI. So we had all patients treated this way during about 9 years of time, 172 patients, elderly patients, and almost all had bleeding risk factor. Almost all had de novo lesions, large coronary arteries, and also complex lesions were involved because almost half of the cases some device to bulk calcium was used. Half of the patients had periprocedural DAPT, but all were discharged on single antiplatelet. Most of the antiplatelets were the milder ones, aspirin or clopidogrel, and 60% of anticoagulated patients had 3 months or shorter single antiplatelet duration, and only anticoagulation thereafter. We divided this population to patients on OAC or no OAC, and we didn't see any difference between the MACE rate or significant bleedings. There was a trend in more bleedings in the OAC group, which is not surprising, but the bottom line is that the MACE rate was acceptable, I think, due to the very comorbid and old population in this registry. And on the safety side, there were no acute closures in spite of lacking the dual antiplatelet therapy, and also ischemia-driven TLR was very favorable. Also, Dr. Cortese has her own registry published this year, 100 patients, which were also very sick patients, anemia, anticoagulation, malignancy, very predominant in this cohort. In half of the patients, type A to B dissections were left in the vessels. Aspirin was used in 1/3 of the patients, and clopidogrel in the rest. And mortality rate, obviously, in sick population was 7%, but TLR rate and MACE were, I think, acceptable. So we have to prove this concept, and I think I hope that the debate trial will do that. We will randomize stable patients and patients with ACS, excluding STEMI, and having de novo lesions in native coronary arteries or bypass grafts, and BARC, high bleeding risk score after peridilatation 1-to-1 using any method. And if there is no recoil or TIMI under TIMI 3 flow, we will randomize either to paclitaxel-coated balloon or any DES with CMARC for 1 month DAPT. And the bottom line is that there is a different antiplatelet therapy between the groups, so that, for example, in stable CAD, only single antiplatelet is used, and in ACS, the duration of DAPT is only 1 month, as compared to the 3 months of duration according to the present guidelines. We will have centers from Finland, UK, Germany, France, and Spain in this trial. Currently, we have randomized a little bit over than 10% of patients to this trial. I would like to stop my presentation with a couple of interesting cases, if I have a little bit time. This is an elderly patient with hematuria and NSTEMI, calcified LAD, which was rotablated with 2 burrs. Then non-compliant balloon dilatations followed by 2 long DCB treatments. This is the initial result showing good flow, no ADP receptor blocker. And this is 5 years after the initial procedure, and LAD is still open, and this approach using rotablation and DCB only has been shown in a few small registry trials. And this patient was very interesting from actually this week's Wednesday. This initial angio is from last year. The man had aneurysmatic coronary arteries, operated abdominal aortic aneurysm, and had cipher stents in LAD, and you can see the aneurysm. This kind of patients is quite difficult to be treated by conventional drug-eluting stents. It was treated by NC balloons followed by 2 long drug-coated balloons. This is the initial result a year ago. Quite nice, I think, according to the situation where we left. And this is the right coronary artery at that time. We had control CT angio 1 year after the procedure because of this aneurysm here. And it indicated invasive coronary angiogram, which was done 2 days ago. This is the result in LAD. You can see that the result has sustained. The small aneurysm in LAD is there, but is stable. But then this is the right coronary artery. And as you can see that there is also a tight calcified stenosis with variation in size of the vessel, and we decided to treat this with obviously drug-coated balloon because of the variation and calcium. If you wonder what I did to the aneurysm, I used 5 covered stents, so it's not possible, obviously, to use drug-coated balloon in this scenario. So I would like to stop here, and thank you.
Tim, that was fantastic, thank you. The last speaker of the session, I think he must pay an extra amount to always have the last word, because he's last in this session again is Patrick. And just remember, it's lunch next.
So I was asked to talk about blended PCI, and my first slide is to say that I don't like the word hybrid. You have a digon there. Hybrid animals die prematurely, and hybrid animals are genetically not reproducible, okay? But I like the word blended, because blended wine mixing Merlot, Cabernet, and Shiraz is pretty good, and blended whiskey is savory. But before talking device, let me show one slide on drug. And we don't talk about drug here, which is quite remarkable. In the lifespan, we will see a tremendous evolution of lipid lowering and anti-inflammatory therapies, targeting mainly the young patient. Valentin first talked only about the people who are 20 to 45. He's not interested by the elderly. Now, we had targeting LDL, non-LDL, and LPA, which is the molecule of the year. Now we are in an oral combination of statin and ezetimibe, icosapent, ethyl, and bempedoic acid. We have seen the monoclonal antibody against PCSK9, monthly or bi-monthly. We have the antisense oligonucleotide, this one weekly or monthly, eliminated a great deal of the triglyceride. We have the silencing RNA, inclisiran against the PCSK9. We are in the middle of a big randomized trial with multi-slice CT scan for primary prevention, and olpasiran, which basically eliminates your LPA from the blood, and that's 2 injections per year. Then there is the vaccination. Then I get very excited by gene editing. As a matter of fact, the genome editing is working. You have Sek Katiseran, which is from Harvard, who has created his own company, Verve Therapeutic. He has gene editing for angiopoietin and PCSK9. That's one single injection, and your cholesterol is for 50 milligrams for the rest of your life. Do you realize that? And he has now a trial with 40 patients with familial hypercholesterolemia. And then on the inflammatory, we have the colchicine. There is a lot of ligand, again, interleukin-6. You give that MAB, and your CRP disappear from the blood, and also the inflammasome. Good. Will atherosclerosis disappear? That's a good question, It's not a joke. I mean, don't forget that after the Second World War, streptomycin and penicillin came, and the infectious disease almost disappeared, at least for if we didn't have the resistance on antibiotics. So you could think that in this decade, with the acceleration of the COVID has been the big things. I mean, nobody is afraid of the silencing microRNA these days. I have 5 times, I'm okay, yeah? So I think it's quite interesting. For sure, we will have soon a Courage 2, an Ischemia 2, and an Orbiter 2 or 3 or 4, yeah? And PCI will be again under attack of non-invasive pharma. So get prepared. Interventional cardiology should work in symbiosis with optimal medical therapy, or OMT will take over. Now, back to the future, blended therapy with DCB, BRS, and DES will be the norm in PCI. For the young patient with non-calcified plaque with flow limitation, clearly we want to avoid permanent metallic caging. We want to have drug coating balloon, bioresorbable scaffold, and pharma-induced plaque regression. The big hype with the DCB is that you don't cage, but then take advantage of that. The plaque burden is still accessible to anti-atherogenic drugs, and we see plaque regression, and we see late lumen enlargement. In the elderly, we have no choice. We have to break the calcium with non-compliant, high-pressure cutting, scoring, rotational orbital atherectomy, and lithotripsy. The dream of leaving nothing behind is still very much alive. And I show you this slide this morning, and I want to show again that this trial, which was done in the last 2 years, is using intensively scoring balloon, non-compliant, and cutting balloon in the 2-group randomized. And next year, you will hear the result of that trial, cage-free. Now, I show also this slide to say that it's overcrowded, but efficient retention and duration in the vessel wall is the name of the game. Forget a little bit the first 3 columns, but concentrate on the red one. tissue concentration at 30 days, 21 nanogram per milligram, and at 60 days, 90 nanogram per milligram. That's the solution system, and they just provide to the FDA the 90 days, which is quite impressive to be. So we are very in parallel with the everolimus eluting stent. Others are sometimes less efficient. You take that one, which is 0.180 nanogram per milligram at 30 days. That's the reason why you have to use a logarithmic scale in that diagram, because basically you have 100 times less in the vessel at 30 days. Now back to the future, 35 years ago, déjà vu. This is a paper that I published in Circulation in 1988. I put on the table every month 100 patients, okay? So I get the loss after POBA, and you could see that the loss disappeared basically after 4 months. After 4 months, we had 0.42 millimeter. I keep working on that, and then in Circulation 94, I pull pharma trial, Carpor, Mercator, Marcator, and Park, 3,076 patients. And you know what? There is a linear relationship between acute gain and late loss. Late loss is on the vertical axis, acute gain is on the horizontal axis. I put as a covariate the MLD, and the bubbles there is the number of patients that you have that. Now that slope, at that time we call that the taxation, okay? And the taxation is something very, very important. This is a drug-coating balloon, 2 drug-coating balloons mixed in one group. The acute gain is here and the taxation is there. That's the slope, 0.60. For every millimeter that you gain acutely, you will lose 0.6 as a late loss. But not every drug-coating balloon is equal. You see that population I show you is composed of 2 groups. The drug-coating balloon A, which has a slope of 0.73, and the drug-coating balloon B, which has a loss of 0.33. So for every millimeter that you gain acutely, you lost only 0.33. And there is p-value for interaction between these 2 instruments. I show you that this morning, OCT in 96% of the DCB, you have a fractures of the intima and dehiscence. And apparently in that experience where we measured in more than 100 patients, frame by frame, the volume of the dissection, you could see is a nice software which is doing that for us. It is clear that also you can demonstrate and discriminate between 2 drug-coating balloons. This is the volume of dissection, who goes, in this case, even 25, but in this zoom diagram you see 21. You could see that with the blue of green DCB-B, despite the extent of the dissection in volume, there is no late loss. So you could say the drug-coating balloon B eliminates the late loss due to the barotrauma of the dissection, while the other does not. Now, this is for the drug-coating balloon, but what about the bioresorbable scaffold? You get cage initially, but at the end you get uncaged. And you know, we studied that intensively, and initially with the Absorb we had something which is 150 micron, and these thick and wide stress create high shear stress in the early version and activate the platelet and hampers the endothelial coverage. This is the work that we did in patients. You could see really the impact of the low shear stress and high shear stress. That's quite complex. Good. Now, will the bioresorbable scaffold with below 90 micron come back? That's a good question. We had planned a trial called Marathon, and the Marathon was bioresorbable less than 100 versus death. And guess what happens? Suddenly, when everything is ready, somebody, I will not tell you, said, why we don't do the biodegradable scaffold versus the drug coating balloon? So basically, the decision is closed, will fall on June 19, but that will be probably the first trial with a comparison of biodegradable scaffold and drug coating balloon. And in this decade, we will see the return of the Jedi, you know, the bioresorbable scaffold. This is one that I'm very familiar from. We worked for many years on this one in University of Delaware, Hartsorb. It's multi-layer of film. You see the film? This is the polymer, this is the film. And then these film are wrapped up in a tube, very strong, with 70 to 90 thickness, but with a stone-size strength, like a bare metal stand, I mean, in the range of 630. You will see this illustration in an editorial on the paper of Greg Stone in JACC, and I put the 2 patent. So if you are interested, you can go there. The magnesium alloy has made big progress. They have the anti-corrosion coating slowing down the magnesium, and they have considerably improved the heterogeneous crystal grain and high purity. And we are all impressed by what Michael Ode is presenting, because he went from a loss of 1 millimeter to 0.64 millimeter to 0.44 millimeter, and now at the in Washington and at PCR, he presents 0.21 millimeter. And to give you another example, what was in the basket is this one, which is fibrillated polymer, filament polymer. But then what I have never seen, that's the first time after 35 years of experimental work, we saw endoluminal elastin. Never seen that before. And that remind me basically the Lima and the Rima. So that's quite interesting. Can you move that slide? Oop. Nope. Okay, I don't know what happens. So that technology is probably going to competing, and has 2 more to show you to finish. Go down, go down, go down. Yeah, I can move by myself. So one thing which is, I think, very amazing is that new technology, the bioadapter, which is a drug-eluting stand and a scaffold, partially uncaged. Basically, you have 3 thin 71 micron of cobalt chrome helical sinusoidal strand, and then you will see between these strands, you have a link of PLLA biodegradable, which unlock the scaffold circumferentially along the 3 uncaging elements in each ring. And therefore, the following neointimal formation and healing unlock the helical strands and continue to provide dynamic scaffolding. I think the results presented by Robert Byrne are quite amazing, to be honest. First, you restore the normal vessel pulsatility. This is stationary OCT, and you could see that in diastole there is an increase of the lumen area but also of the bioadapter area, and that increase is 14%, bioadapter 9%, here 9%, and theoretically that gives you a 30% increased blood flow between systole and diastole. So the last point is that, to our surprise of everybody, the plaque volume basically behind the stress has a progression of 12% in the resolute onyx, but only 3% in the dynamic X. So that's something which is quite important. The last slide, I think, is, just one word about the thin struts. It's clear in these meta-analyses that all the thin and ultra-thin induce a reduction of 25% in TLR. We should not forget and neglect that. So the conclusion is a slide which is an embargo, so it will disappear very quickly. Yeah, you don't have the time to take pictures. Yeah, but with blended therapy, interventional cardiologists will be confronted with complex algorithm of treatment that will not make our life easier. When do we mix all these things? Yeah, thank you.
Well, thank you very much. Absolutely brilliant. There are any questions from the audience? I'll just remind you that we are off time because all the speakers have been here. None.
Patrick, it was very interesting to see this bioadapter in the PCR. Do you see any analogy between this kind of stent and stent fractures for which we have always been concerned?
I will tell you an anecdote which is very old. I don't know if you remember the B stent. The B stent was people in Israel, and they make these big long stent of 40 millimeter. And then one day they call me in catastrophe and say, the stent is broke in 10 segments. I said, that's fantastic, I would like to have that. And what they did is that they put the stent of 40 millimeter in a small pig of 40 kilos, and then 1 year later, when the animal was 300 kilos, they did the control. But that was the concept to separate these things was there from the beginning. One of the very first stent, the AV stent, has no connectors. And it was purchased by Medtronic and became one of these stents. So the concept to say, do we need longitudinal or only radial scaffolding is also a good question. But we will see. What is amazing is 1.8% of TLR in that study with side 2 presented by Robert Byrne. 1.8. That's getting low. Yeah? Versus 3.9 for the Onyx, I think. So we'll see. I mean, that's typically interventional cardiology. It's always come from an unexpected corner, you know.
We have a prospective registry with a bioadapter that we started 1 year ago in Milan, and we're using this device in complex lesion, in bifurcation, CTOs. So we are doing angiographic follow-up, and the initial results are very good, but it's too early to say. It will take another 6 months, but definitely our series is really very real life.
You know, one concern that I have, I don't know if you have seen that on the OCT, there is this small evagination. You know, evagination with the fellow in Spain, we didn't like it too much. I mean, with Lawrence Raber, and we didn't like the evagination. That was reason for trouble. So there's a kind of dynamic evagination in between, but you have to watch. Yeah?
I've been impressed by the cases presented by Thomas Riersimon. I really wonder, after you presented this case, why do we have concentrate only on high bleeding risk? These are excellent. Everybody should first be evaluated like that.
Yeah.
You don't need anything.
Just a couple of short questions because I think there are some issues missing. First to Simon. What do you need to do to convince these people in the bifurcation club that drug-coating balloons play a role in bifurcation? So that would be my question to you, and I know you'd be interested in that. Bifurcation club, all these documents, and still there is no role for drug-coating balloons. And the second for Thomas, okay, I will tell you high bleeding risk, drug-coating balloons are very attractive, but there are all these studies proving that with just new generation drug-coating stents, we can also do virtually the same. So what would be your answer to that?
Yeah, you can, but you still need 1 month DAPT, and half of the bleedings occur during the first month. So you cannot get rid of the problem using the modern DES. So I think we need to improve. And then also the long-term results that we have seen are still not optimal. We have 3 to 4% dose rate after the first year after stenting. So there's no plateau. So
there is one thing that our friend Japanese should do for us in Europe. It is they still do angioscopy all the time. Okay, they still have an excellent instrument. So when you put a stent, drug-eluting stent, bare metal stent, etc., if you inject cardiogreen, which is the dye approved by the FDA 40 years ago for cardiac output, then the only things who get green is the stent, especially the drug-eluting stent, because the connection between the endothelial cell is very poor, the cadherin, the protein 120, and the dye goes through. It's a 40 kilodalton, and it goes in the subentima, which is full of lipid, and it became green. But if you do drug-coating balloon, I would not be surprised to see that it will be white, not green. And that will be the best demonstration that you have good endothelium without killing the patient and doing a von Willebrand factor and all that. Yeah. So if there is somebody who knows a Japanese doing, he should go in that project.
In answer to your question, Fernando, about the European Bifurcation Club, I think there's a couple of things to bear in mind. One is politics and the second is mindset. Having said that, we could discuss it further over lunch, and I think it's lunchtime, isn't it?
I did consider the work on bifurcations, and I changed completely my approach. I always, frequently do pre-dilatation and kissing balloon on both branches if they are 1-1-1. That is the real bifurcation. And then I make the decision. Because after pre-dilatation, including kissing balloon, if you have a good result, you don't need to stent. Not even the main branch and the side branch. So, very practical approach.
So I think we can now go to lunch. Thank you very much to everybody, and thank you very much to the speakers and panelists and my co-chairs. Thank you.